Thank you, Mr. Chairman and members. Again, my name is John Hawkins. I'm with the Texas Hospital Association. Want to appreciate the opportunity to talk to you about a very important issue, hospital finance in the state. I think in your materials you should have a document that we put together that is called a Hospital Financing Overview, and I think it kind of goes into some detail specifically about the kind of the financial profile for all hospitals in Texas. And again, THA is the statewide association that represents most hospitals in Texas, urban, rural, not-for-profit, investor-owned, and public hospitals. And so, again, this I think provides some good data of all of those members. So before I talk specifically about some of the issues that the HHSC did an excellent job in giving us an overview about, I think it is important to remember a couple perspectives about our state Medicaid program. According to the LBB's fiscal size up, there are currently more than 4 million enrollees in our Medicaid program. And remember, the vast majority of the actual clients are pregnant women and children. And again, it's important if you look at that fiscal size up. If you look back at 2004, there were only 2.7 million in the program. So since 85% of the program is now in managed care, again, this waiver fully implements that managed care program. If you actually look at the per member per month spend on Medicaid over the last 3 biennia, that has been flat, actually has reduced some. And so it's really important to note that it's that population growth, the client growth in the program that's driving the size of our Medicaid program. And so there's a lot of discussion about Article 2 and how much of the state budget that is consuming, particularly compared to Article 3. And again, I think that's an important discussion. But you need to remember, and again, I'm looking at the LBB fiscal size up, that is really an all funds comparison when you look at that. So if you look at just the general revenue that's allocated to Article 2, it's about 34.4 or 30.4% of the total GR spend in the state. And again, still significant, but public education, Article 3, is actually 52.8% GR funded. And when you look at that GR spend, if you go back to 2010, 2011, it was actually about the same, 30.3%. So really, the majority of Article 2 are the federal funds, and I think that's important to remember when we're looking at
because, John, when you add the federal funds in, it's not exactly equal, but they're both one. I think Article 2 is just under 37%. Article 3 is just over. Is that right? That
is correct.
So
that's correct.
You're saying if you take the federal portion out of that, there's a pretty big difference.
Right.
Okay.
Right. Yeah. So I think that's important to remember. So again, moving on to the specific items at hand, we certainly appreciate the legislature's commitment to partially fund hospital financing the last couple sessions. And again, the commission did a good job of laying that out. A couple sessions ago, you put general revenue in to the DISH program, which was very important to keep some stability in the system because of changes that the waiver brought about on our method of finance. We certainly appreciate the targeted rate increase that you fought very hard for last session because, again, that created stability. I think it also gave some good signaling to CMS about your commitment to hospital rates, recognizing that the coverage expansion issue has been problematic for a number of reasons, and I think that actually helped with our 15-month extension. So in spite of these efforts, it is important to remember that we have heavily relied on these supplemental payments to fund our Medicaid system in the state, and particularly the Medicaid safety net. And, I think while that has been important for us to make it work over the past 15 years, Pam did an excellent job of laying out that really the current regulatory environment, and again, we can look at motives on CMS's part for a lot of different reasons, but really it's not just CMS, it's the Office of Management and Budget, and the federal government is trying to be fiduciarily and fiscally responsible in looking at the trend line on the supplemental payments, just as the state legislature would be. It really has become a challenging environment going forward. notwithstanding the 15-month extension. So, it's served us well over the last 15 years to kind of keep things patched together, but right now the current funding system has several limitations which are very challenging going forward. The fact that we're only getting paid 58% of cost inpatient, 70-something% outpatient, creates about a $2.4 billion Medicaid shortfall. And again, the commissioner has pointed out, based on looking at Florida and some other states, that's going to be an issue going forward. We got to remember that private hospitals are providing 74% of inpatient care for Medicaid patients and about half of the care for the uninsured. Again, we've got a great system where we have incentives for public and private hospitals to share in the work. There's plenty of work out there to be done, but the current financing system is limiting because of our inability to share the federal funds between all of the hospitals doing the work. Fred, I'm sure, will talk about, the fiduciary responsibility of public hospitals, of his commissioner's court, to make sure their IGT is predominantly serving folks in Dallas County. That issue exists in other places across the state. We cannot continue to allow, the six largest public hospitals to finance most of the supplemental payments in the state. And CMS, again, has identified that as an issue from a regulatory standpoint as well. And again, at the end of the day, hospitals, both public and private, are shouldering the burden of the more than 5 million Texans who remain uninsured. And so if we can't figure out a private market alternative to coverage expansion like some other states have done, that again is going to be an issue with CMS going forward, since there are federal funds on the table ostensibly to help cover that population. So, kind of to wrap up, we applaud the state's work on getting the 15-month extension, but we do know we've got some pretty significant work in front of us. We would, ask the legislature to look at continued efforts to address hospital rates, because that Medicaid shortfall is going to be an issue. We know that we ought to continue to look at trying to do something about the uninsured, because at the end of the day, that cost is going to be stranded if you look at the way CMS has dealt with other states. And just to give you an idea kind of where we're going with this, if you looked at a Florida-type model, we think our UC pool would be reduced from $3.1 billion to something less than $2 billion. And that's at a time when we're projecting that by 2018, the need would be about $8.1 billion. So that's a huge fiscal cliff if we can't work with our federal partners to try to address that. We also need to look at innovative ways to continue the DSRIP projects, either through incentive pools or otherwise, because again, remember we're not just dealing with hospital services, we're also dealing with physician services, primary care, clinic services, behavioral health, lots of readmission type projects that help with reducing costs in the system. So we need to figure out a way to reconstitute those going forward. And just to finalize, I think the reality on all of this going forward from a hospital perspective is really portrayed on the last page here, because you've got to remember that what hospitals are dealing with, particularly at the federal level, are ever-increasing cuts under the Affordable Care Act, because the idea was we would take cuts that increased over time under the assumption that coverage would expand over time, and that's been a challenge on the marketplace side because of some of the cost-sharing arrangements, certainly the decision not to do coverage expansion. And this graph doesn't even include the DSH cuts, Medicaid DSH cuts. Pam indicated those are yet to be determined. You also have to remember there's 2% sequestration cut across the board in Medicaid, which continues on into the foreseeable future. And then the state cuts, which are the managed care expansion, the ER cuts, some of those others that were talked about. So that's pretty much an unsustainable fiscal situation going forward if we don't solve the UC piece, the Medicaid shortfall piece, and the coverage expansion piece. So I'll stop there and answer any questions.
John, do you all have any suggestions or do you take any official positions as an association on what the state might do or should consider with respect to the Medicaid shortfall, that $4 billion figure going forward in terms of sustainable financing options?
So, a couple things. One, we need to, and the state's done a very good job getting in front of this, HHSC. We need to make sure the definition is correct. When Florida did their study, there was some discrepancy about some of the data sources, and we need to make sure we have a defendable number on what UC really looks like out there. So that's job number one. Obviously, any state resources that go in, general revenue that goes into rates is helpful at the end of the day in reducing that number. Other states have looked at self-financing. The industry has looked at self-financing of some of those rates, and we have a working committee at THA right now that are looking at some of those options. So I think all of that ought to be on the table. And then I think, too, we need to remember at the end of the day, this is a negotiation with the federal government, and a good faith effort in a lot of these areas, although not totally closing the gap. CMS knows these services need to be delivered. We've got a lot of need in the state. So we need to make the case that you can't just go from 0 to 60 in 10 seconds. So we need to, it's clear we need to do something different, but we can't go there overnight. And again, that's where the 15-month extension, I think, was helpful because it gives us a little time to work on this.
Okay. Thank you.